Good morning to everyone. My name is Mrs.Mithra Devi. I am working as a nursing tutor at E.S College of Nursing, Villupuram. Today we are going to see about the topic of post-operative management. Post-operative management, otherwise called a post-anesthesia care unit. Okay, so we are going to see about. First, what is mean post-operative care? Post-operative care is a care that the patient receives after the surgical procedure. The type of the post-operative care that the patient need depends on the type of the surgery as well as the patient history. It often depends upon the pain management and wound care. Okay, post-operative care, whatever the area is, after the OT operation theatre, the patient is shifted to the post-operative care, or otherwise it is called as the area called post-anesthesia care unit. And what are the phases comes in post-operative care? First is immediate phase, that is post-anesthetic phase, and second intermediate phase, that is hospital stage phase, convalescent pain after the discharge to the full recovery. Okay, first immediately post-anesthesia phase only we are going to see. Okay, first what are the purpose we are seeing post-operative care? To enable a success and faster recovery of the patient in post-operatively, to reduce the post-operative mortality rate, that is the death rate have to reduce. Next, to reduce the length of the hospital stay of the patient, because the long need of the hospital stay also patient have prone to get the infection. To provide the quality care services in the post-operative area, to reduce the hospital and patient cost during the post-operative period. And post-operative care unit or PACU, I already told. Okay, PACU should be a soundproof. Okay, soundproof patient in soft color. The room should be a soundproof and the room should be a soft color, and it should be an isolated area that is separate from the in ward setups or emergency area. These features will help the patient to reduce the anxiety and promote the comfortable position to the patient after the surgery. Next, phase 1, that is immediate post anesthetics phase we called. Okay, in this area we have to know about as a nurse means what are the sound of knowledge related to the anesthetics drugs. And phase 1, it is an immediate recovery phase and requires the intensive nursing care to detect early signs of the complication in that area. Mostly post-operative ward means post-operatively the patient shifted after the OT in the post-operative ward. We have to know about what are the airway management and blood circulations, airway, breathing, circulation mainly we can focus, and what are the cardinal features we have to know about the anesthesia in the post-operative area of the working. Okay, so receive a complete patient record from the operating room which to be planned on post-operative care. Pre-operative checklist and the intraoperative record we have to receive as the patient shifted to the post-op immediately. It is designed for care of the surgical patient immediately after the surgery, and patient require close monitoring. First we have to see after the patient shifted to post-office vital signs and ABC. Okay, main focuses. And immediate phase, that is discharge from the recovery, should be after complete stabilization of cardiovascular, pulmonary and neurological function, which usually takes 24 hours. After the posterior immediate phase, we have to check about the cardiovascular status and pulmonary, that is breathing, and neurological function or the neurological examination we have to do. Usually it takes 24 hours. And post-operative orders, what are the orders comes in important? First I told you we have to monitor when the patient shifted to the post office vital signs. We have to check the temperature, blood pressure, pulse and everything. Next, ECG, if the patient have more prone to get arrhythmia due to the anesthesia drugs. Fluid balance, the patient has to some drugs have the patient posed to electrolyte imbalance of hyperglycemia or hypernatremia also. And other types of monitoring mainly arterial pulse after the vascular surgeries patients, and level of the consciousness after the neurosurgically patient. Next, respiratory care. Okay, breathing. Okay, first we are breathing here, oxygen mode. What way of mask and what are the ways of mask they are using the patient in that area, and through the which way the anesthesia is given to the patient. Some patients we give anesthesia to the patient through the inhalational forms. Okay, next, ventilators. We have to monitor the ventilator settings of what are the modes or the patient is continuously following, and IS to ratios and tidal volume and PEP. All things you have to check the connections and ET tubes also. Next, tracheal suction. If the patient has have to increase the secretions after the anesthesia, after the post-op because of anesthesia, so we have to clear the suctioning in the mouth. Okay. Chest physiotherapy. Some lung surgeries patients or sometimes the patients needs to drain fluids due to the chest physiotherapy. Next, positions in the bed and mobilizations. Turning the bed usually every 30 minutes until the full of the mobilization to prevent the complications of the patient. Because after the 24 hours 30 minutes, we have to patient have to mobilize. If the patient have able to move means move. Okay, special positions are required sometimes for patients. Some doctors will advise and prescribe the records position, what position have to maintain the patients after the post-op ward. Next, DVT, deep vein thrombosis prevention, mechanically intermediate cough compression. Okay, so cough compression we have to intermediately we have to see the DVT. And diet, some patient have the patient in per oral MPO. And liquids, how the patients have to start the liquid. First we have to check the reflex and after that only we have to give the sips of water. Next, diets we have to start. Okay, that is a solid, first liquid, semi-solid, solid, and normal special diets are according to the patient condition can tolerate after the patient shifted to the ward. Administration of IV fluids. Okay, daily requirements, how much of the fluids are going in the patients, and losses from the GIT and UT. Mainly the intensive care units or a PACU or a ward, the patient will maintain the GI tract through the what are the fluids are discarding, and intake output we have to maintain properly. Incisible loss, through the incisible loss, that is through the breathing or any sweating, how many fluids are losing. And care of the renal patients, some patients they are put in the catheterization, how much of the urine output will comes after the surgery. And care of the drainage too, what are the drains are available, how much of the drains fluids daily coming out from the body, and what color pattern, see at which time we have to record proper post-op order. Okay, and what are the medications are used in the post-operative wards, antibiotics, painkillers, sedatives, care of the patient on pre-op steroids sometimes, H2 blockers, anticoagulants, anti-diabetics and antihypertensive drugs we can use. Depends upon the patient's condition and what are the surgeries we are done. So depends upon the sometimes medications we are using. Next, post-operative war in pulmonary care we can see. Okay, example, ventilator patients. Functional residual capacity and vital capacity decrease after the major intra-abdominal surgery down 40% of preoperative level. That we have to monitor. Then go up slowly to the 60 to 70% of the 7th day to normal preoperative level after that. Next, functional residual capacity and vital capacity post-operative pulmonary edema contribute to the change for the pulmonary function spots. Okay, next, the above changes are accidentally by the obesity, heavy smoking and pre-existing lung disease, especially in elderly patients. Okay, next, post-operative pulmonary care, atelectasis, most important complication of the pulmonary after the post-operative ward is atelectasis. Okay, so it enhances shallow breathing, pain, obesity, abdominal distension and restriction of the diaphragmatic movement, that is called atelectasis. Sometimes we call the lungs collapse. Okay, post-operatively physiotherapy, especially deep inspiration, helps to decrease the atelectasis. So to prevent the atelectasis, we are giving a breathing exercise to the patient or pursued lip breathing to the patient, and also the oxygen mask and periodic hyperinflation using a spirometry. Mostly preventing atelectasis, we are using a spirometry after the lung surgery patients in the ICUs, or breathing exercise, that is pursued lip breathing or spirometry. Okay, early mobilization helps a lot because of to prevent a prolongation of the without movement of the patients. We can more prone to get to increase the calcium level to the patients, so patient goes to hypercalcemia. So antibiotics and treatment for the heart failure post-operatively by adequate management of fluid will help to reduce the pulmonary edema. After the post-op of the CT, the cardiothoracic surgery, some patients will have to maintain a fluid volume correctly to reduce the pulmonary edema in the PACU area. When can the patient can leave room The patient is fully conscious. That it means when the patient have to shift to the ward, patient have fully a consciousness, respiration and oxygens are adequate. That means if it is a patient on ET, endotracheal tube, means after the extubations the patient properly has comes to the face mask or nasal bronchs. Okay. Next, patient is normotensive, not in the pain or nauseousness. Cardiovascular parameters are stable. That is, every cardiovascular status of the measurements we have to monitor and should be staged. Oxygen, fluid and analgesics have to be prescribed. There is no concern related to the surgical procedures. These points will come after the patient shifted to the ward. General postoperative, what are the problems will come? First is pain. Okay. Nociceptive pain arises from inflammation and ischemia. Neuropathic pain arises from dysfunction of the central nervous system. Psychogenic pain is modified to the mental state of the patients. Surgical patients may have a persistent pain from a variety of the disorder, including chronic inflammatory disease, recurrent infection, degenerative bone or joint disease, nerve injury and sympathetic dystrophy. Effective analgesics is essential part. Okay, you have to give anesthesia at the intraoperative ward, that is effectively, that is only the patient are able to properly come to the reversible loss of sensations and came to the consciousness in the postoperative after the patient recovery to the shifted to the ward. Important injectable drugs for the pain or opioid analgesics, that is NSAID such as diclofenac, ibuprofen, paracetamol can also be given orally. Commonly inexpensive opioids are pethidine and morphine only. Fluid and nutrition. Okay. Fluid therapy and nutrition supports are fundamental to good surgical practice after the patient post-op. This is require a knowledge of sequence of surgical intervention in particularly and intestinal resection. Malnutrition is common in hospitals. Most of the patient is admitted to the hospital. Some patients, mostly 90%, 80% patients goes to malnutrition. So, fluid and nutrition is very important to taking care of the patients of post-op ward. All the patients have to sustain who likely to sustain 7 days of inadequate oral intake should be considered for oral support. The success or otherwise nutrition support should be determined by the tolerance to nutrition provided and nutritional endpoints such as a weight. Mostly after the post-op, fluid and nutrition management we are maintained. They are checking regularly weight in the ward. Next, nausea and vomiting. Nausea and vomiting occur when there is a stimulation of vomiting center of the multiple factor in the brain. Adequate treatment is pain, anxiety, hypotension and dehydration. And antiemetics, what we are using, HT3 receptor antagonist, that is ondansetron, and steroids, example dexamethasone, rarely we can. First preference is ondansetron only, and if it is not available we can give other is dexamethasone steroids. Next, bleeding. Okay, the patient blood pressure, pulse, urine output, dressing, drain should be checked regularly in the first 24 hours after the surgery. Okay, if the bleeding is more than expected of the given procedure, then pressure should be applied at the site and blood sample should send for a blood count, coagulation profile and cross matching. Fluid resuscitation should be started. Ultrasonography and CT may be arranged to determine the size and extent of the hematoma. If immediate control of the bleeding is essential, the patient may be taken back to the operation theatre immediately. If the surgical hemostasis is not successful, using the method hemostatic dressing or surgical glue may be tied. Deep vein thrombosis. This is one of the complications for prolongation of the stay in the after the post-op ward in the patients. Patients suffering from post-op DVT may be present in a cough, pain, swelling and redness and engorged vein. However, most will show no physical signs. On palpitation, muscles may be tender. There is a positive Hohmann signs. We can check the Hohmann signs, cough pain or dorsiflexion of the port for deep vein thrombosis. And venography and duplex Doppler ultrasonography we can use after the Hohmann signs is positive to assess the flow and presence of the thrombosis. And management. How to manage the DVT is use of stocking, cough pumps, lower molecular vein, that is heparin or enoxaparin. Okay, heparin group, enoxaparin, they will give advice for lower molecular vein. Hypothermia and shivering. This is one of the complication for the anesthesia after the post-op. Anesthesia induced loss of the thermoregulation centers. Hypothermia is due to exposure of the skin and organ, a cold operating environment, volatile skin preparations, infusion of the cold IV fluids. This is turn led to the increased cardiac mobility, hypocoagulated state, shivering, wound infection. Active warming devices should be used to treat hypothermia as appropriate. Most common cause of post-op fever when the starting is first day is reactive to drug or surgical tissue trauma, the fever start. Second day this atelectasis is the most common complications, and third day have chance to come a IV line infection. Fourth day have to come a pneumonia, DVT and UTI if the patients have urinary catheterization, the patient also. Fifth day have chance to come wound infection. Sixth day abscess somewhere. After first week, allergy drug, transfusion relation fever, septic pelvic vein, thrombosis, intra-abdominal abscess. Okay, these are the most common causes for post-op fever when starting on. Infection. Prophylactic antibiotic should be administered in patients who are a foreign material inserted during the procedure, include hip or knee prosthetics in orthopedic surgery or aortic valve in cardiac surgery. Up to 3 doses they give antibiotics. Usually 1 dose 30 minutes before knife to skin. When the knife to skin to post-operatively. Prophylactic antibiotics appear to reduce the risk of any contamination developing into infection by destroying bacteria before they are incorporated into biofilm. Pressure sore. This occurs as a result of friction or persisting pressure of the soft tissue. They particularly affect the pressure point of the recommend position, including sacrum, greater trochanter and heels. Early mobilization prevents a pressure sore, while those who are unable to turn in bed should be turned every 30 minutes to prevent the pressure sore from the developing. High-risk patients may be a nurse on airlet mattress, which automatically relieves the pressure areas. Drains. After the post-operative surgically, some patients haunts a drains or two. Drains are used to prevent the accumulation of blood, serosanguineous and purulent drain, allow the early diagnosis of leaking of the surgical anastomosis. The quantity, character of the drain fluid can be used to identify abdominal complications such as fluid leakage and bleeding. This lost fluid be replaced with additional IV fluids with the same electrolytes contents. Continued loss of blood through the drain should be investigation for the source. Drain should be removed as soon as possible, and certainly once the drain has stopped or become less than 25 ml per day. Wound care. Epithelialization takes 48 hours. Dressing can be removed 3 to 4 days after the operation. Wet dressing should be removed earlier and changed. Symptoms and the signs of infection should be looked for, which we present compression, removal of few stitches and daily dressing with swab or CNS. Tensile strength of the wound minimal during the first 5 days, then rapid between 5 to 20 days, then slowly again. Full strength takes 1 to 2 years and good nutrition. Respiratory complications. Most common respiratory complication is hypoxemia, hypercapnia, aspiration, pneumonia, pulmonary embolism. Pulmonary aspirations and prevention and treatment of the aspiration is preoperative fasting, proper positioning of the patients, careful intubation, single dose of H2 blockers and endotracheal suction immediately stimulate the coughing, which helps to clear the airway. Cardiovascular complications we can see post-operative dysarrhythmias, post-operative myocardial infarction, post-operative cardiac failure, severe hypertension. Renal and urinary complications are acute renal failure, urinary retention, urinary infection. Complication for specific surgery is abdominal complication, urological complication, thoracic complication. Abdominal we can say complication where paralytic ileus, bleed, abscess, anastomosis, leak. Urology complication is mainly a pulmonary edema. Neck complications, thyroid surgery, neurosurgery, increased ICP, thoracic complications. Enhanced recovery when early planned physiotherapy and mobilization is enhanced, the patients have recovery and shift to the ward. Early oral hydration and nourishments, good pain control. Discharge planning include plan for follow-up physiotherapy and other supported needed. Nursing management in post-operative care unit. First, assess the patients, that is assessing the patient. Frequent assessment of the patients for oxygen saturation, pulse volume regularly, depth and nature of the respiration, skin color, depth of the consciousness. Next, maintaining of the patent airway. The primary objective are the maintaining of the pulmonary ventilation and prevent the hypoxia, hypercapnia, provide oxygen and assess the respiratory rate and depth, oxygen saturation. Third is maintaining a cardiovascular stability. Assess the patient's mental status, vital signs, cardiac rhythm, skin temperature, color, urine output, CVP, that is central venous pressure, arterial lines, pulmonary artery pressures. Next, relieves the pain and anxiety using opioid analgesic. Assessing and managing the surgical site. Observed for bleeding, type, integrity of the dressing and drain. Assess and managing the gastrointestinal functions like nausea, vomiting, cough after the anesthesia and check off. Assessing and managing the voluntary voiding, encourage the activity. And I refer the book of Poster Bailey Lowe Stott Practice for Surgery, Chapter 1, Postoperative Care. Thank you.